Our next speaker is Dr. Emad Salloum. He's a DDS degree from Damascus University 1981 and Syrian board certified in oromaxillofacial surgery in 1986. He's ICOI diplomate and master's in implant dentistry. He's an owner of a multi-practice dental center for oromaxillofacial pain and implant. Please all welcome Dr. Emad Salloum. Thank you.
Thank you all.
Thanks, Dr. Sure, take support.
Yeah, okay. Give me my time and don't put pressure because we really all enjoyed what Christian Kochman did. He is always amazing. Well, thank you all for your presence. Thank you, Ritter, for giving me the chance to be with such a great lineup of speakers. It didn't match. Okay, well, it's really amazing to be on this podium, sharing this podium with such a great line of speakers and really awesome friends of mine. We have been lecturing for quite a long time together. To share with you my topic today about, which will be very critical, maybe, for some of you, to share my own mistakes I'll step back here, okay? It happens to you, Raquel. It's the same. The cutting edge complications versus mistakes in immediate implantation. We've been listening all day about, from the Agnini brothers, from Romanos, from Ricardo Kern, about what happens with us with the immediate implantation. Actually, it will be for me like a retrospective review of my complications, my mistakes during the past 20 years of my immediate implant practice. I've been practicing implants now for 32 years, but immediate implantation started only 20 years ago. I'm sorry. My God. Okay. We all remember the story of Thomas Edison. Thomas Edison tried to invent his electric bulb, the electric bulb, with 2,000 filaments, with no success, total failure. As his assistant got bored of him and told him, well, all our work has gone in vain, and we have learned nothing from our experience after trying 2,000 filaments. And his assistant, so Thomas Edison answered, no, you are absolutely wrong. We have learned a lot of things. At least we have learned that those 2,000 elements are not good for the electric bulb. Just 1 month later on, Thomas Edison was able to invent his innovation. Almost the same story happened with the immediate implantation. It's not new. It started by Professor Schulte during the late 70s, where he placed an all-ceramic implant. It was called at that time Frialet 1 implant. And then the story began with the somehow of success. It's not a full success. Reviewing the literature by the end of the 90s and the beginning of the 20th centuries showed many cases or many reviews about a big success of immediate implantation. But this immediate success, well, how about 96% according to Young? 96%. It's better even than the regular implantation. And that drove us to go. That's what I want. That's what my patient want. They want fewer appointments, less treatment time, less cost, and everything goes well. That's what I want. So I was eager to go for immediate implantation. Reviewing all the literature at that time said, the good thing, I'm sorry, it's not here, but the main advantage of immediate implantation that if you place your implant simultaneously after extraction, you will avoid all the negative effect of the extraction, which is the bone resorption. That's what we thought at that time. But to be able to do that, you have to place a wide diameter implant according to Team Atlanta at that time in the 2001. You have to place a wide diameter implant that mimics exactly the shape of the socket. All the literature thought that they have to manufacture, design a new implant that exactly looks like the socket, a wider implant to use, in a way that enables us to get the excellent primer stability in the socket. This is one of the first cases that I did in 2003, unrestorable tooth. Of course, atraumatic extraction. I placed my implant according to the standards, according what all the research said. 4 months later, the healing was uneventful, excellent, but look at the prosthetic work. 4 months later, if you look at the zenith line, I lost about 1.5 millimeters or 2 millimeters of the bone. Well, Paolo Antonio used to say, if you place your implant, you will avoid all the negative actions of the resorption bone. What's happened here? This is a surprise for me. The second case came in 2003. I was happy. The patient was so eager to try the immediate implantation. 6 implants in the upper jaw. 4 months later, I was able to fabricate my prosthetic work. I was so happy. The patient was so happy. But 2 years later, not more than 2 years, look what happened to one of my implants. Exudation. In fact, I lost this implant. The patient lost this implant. Why? At that time, I had to go to the Bible of implantology. It was the second edition by Carl Misch. Then I think maybe it's the zipper effect, maybe more stress on the bone. I thought this is the only reason for that. And I was thinking, is it really, do immediate implants prevent bone loss? This question. In fact, no. Why no? Because 2 years later, or at the same year, but we didn't read, Arujo and Linda, they published that bone resorption and gingival recession is something unavoidable, totally unavoidable, even if we place our implant immediately after extraction. But this is something that we didn't know before. Danny Boozer, he said, maybe it's not only because there will be a recession. In 2004, he said, any implant touching the buccal plate will definitely go into a resorption. So now we started to notice why. Do you remember this? Do you remember this case, Omid? Okay. Now we started to remember why this is happening. Danny Boozer said, it's touching the buccal plate. When you touch the buccal plate, you'll get a resorption. Maybe because we were using wide implants as the recommendation of the Salama brothers. Then the research said that no, the more success rate is happening with the narrow platform implant, not the wide implants. So we started to change our look to the immediate implantation. Only Van der Wijan said wider diameter implant engaging the buccal plate. Now we started to know the reason. Howie Gluckman, who we see presenting after me on this podium, said in 2006, all our understanding of the immediate implantation was totally, absolutely incorrect. And we have to change. Many techniques proffered in 2003 are now mostly totally neglected. So we have to change all our understanding of that. In 2007, Team Atlanta and Team New York worked together in finding how to place our implant in the ideal positioning. This is an excellent article. So we learned what is the ideal positioning, when to place the implant, and how to place the implant. Then, at that time, I went back to my cases. My surgery opened the flap, and then I discovered, if you take a very good look at those implants, all of them, just by accident, they were away from the buccal plate. Only this implant that I lost was touching the buccal plate. So that was the reason. That's why going back to your old cases will give you a very good idea about why you get this complication. So in this case, if I had placed the implant in a little bit palatal positioning, I would have avoided all the negative effect of the immediate implantation. Then, some of the authors would say that, no, I think that the resorption in the buccal plate is related to raising a flap. At that time, you saw all my cases with raising a flap. They said, if you raise a flap, the blood supply for the buccal plate will be affected. So now for immediate implantation, we have to start doing it flapless, incision-less. And all the studies in 2005 and 2004 showed very high success rate to be doing flapless implants, immediate. Well, this is my case. In 2004, I started to place my implants flapless for selected cases. A traumatic extraction, ideal case. I used a simple guide that we had at that time, placed my implants correctly, and look, very nice healing. Placed my abutments. At that time, it was cemented, and the final restoration, I could have closed my eyes in front of my patient. What did I do? I had 2 black triangles. What a shame to have that. Why? Why did I lose all the bone under this papilla? I did everything according to the protocol, what they said. And I started to say, not only me, a lot of dentists would start to say, and stop doing immediate implantation. Do we have to stop? Does immediate implantation increase the bone loss? Maybe. Let's see what literature says. So going back to my cases and going back to the research, what Dennis Tarnow said about the tooth positioning, where to place our implant, as Romano said, as the Agnini brothers said, about the positioning of our implant. Now we are going to understand a new era in understanding how to place our implants in the 3D correct positioning, which is very essential. In literature, Dennis Tarnow said, if you place your implant in a way that the contact point is more than 5 millimeter, 6 millimeter, you will start losing the dental papilla. 7 millimeter, in 75% you will lose the dental papilla. Now, I have to go back. After reviewing what Dennis Tarnow said, I have to go back to my case. This is the x-ray of my case. Taking a closer look, this is the wrong positioning. Almost kissing implants because I placed a lateral and a central. Almost kissing implant. It's not the problem of a kissing implant only. I should have placed them a little bit apart in a way that I have a 3 millimeter. Because this is the ideal. I should have placed them in a depth in a way that I get only 5 millimeter between the bone and the contact point of my final prosthesis. And this is very important. What shall I do in this case? How do I correct? Alain Romanos showed us how many cases he tried to correct after the complications. He did or other practitioners did. The only weapon I had at that time for this case is to understand the concept of platform switching. And I took the advantage. What does that mean? It will minimize, if you use the platform switching, it will minimize the residual bone, interproximal bone recession. So what I did, I just took up the prosthesis, placed two narrower diameter abutments, and start with the new temporary prosthesis, and I started to pray to God to get a creeping papilla. If you see, I started here in 2008. I started to get a creeping papilla. But it took me 2.5 years, changing the temporary prosthesis until I reached the final result, which is acceptable. I tried to correct my complication, my mistake, in an acceptable way, but it's not the perfect way. Now, 2011. So it took me to the final step almost 5 years to place the final restoration, which is acceptable. It's not perfect. The Agnini brothers mentioned today about this central lateral dilemma. And this reminds me, meeting one of my awesome friends, great mentor, Dr. Maurice Salama, when he was discussing this issue, the central lateral dilemma, where he claims that this issue can be totally avoided, as the Agnini brothers showed us this morning. Totally be avoided. Just place one implant. There's no need to place two implants for a central lateral. Just place one implant and one pontic, and this will be solved. So now we learned how to place our implant in the totally correct 3D positioning. Be away from the buccal plate. Okay, this is in the 3D positioning, the depth corona apical positioning, the adjacent teeth, taking place the central of the implant with the center of the cingulum of the adjacent teeth. Okay, this is all we learn. Thank you, Amit. This is one of your slides that I took from you. In the day zero, Ernest Arnault said, but how about the gap? Everybody will ask himself, okay, what do I do with this gap? Will it heal? Of course. Ernest Arnault said, it will spontaneously heal, don't worry. The day zero, you have a big gap. In 1 week, it will be narrower. In 9 weeks, it will be a total healing. But there is a bone remodeling. The bone didn't keep. It will be excellent osseointegration. This gap will be filled with bone, but it will not protect from the bone remodeling. Okay, what filled this gap? What filled this space? It's just like healing like any normal socket after extraction. It's filled with blood clot. You would ask yourself, why this blood clot, why the epithelium tissue would not invade this space? Because this blood clot is a dead body. And the epithelium is not able to grow in that body. So, the gap is filled by blood clot, which is dead. It's the same biology that happens with the extraction sockets. Then, why to graft? Do we graft it? Yes. Why? It's only to minimize the socket collapse. It's not for osseointegration, it's just minimizing the socket collapse, that this remodeling will happen and happen. It's nature, it's Mother Nature. So grafting this space is essential just to maintain the contour of our bony and soft tissues. But it does not prevent the remodeling. A lot of research, Kadrapoli says that we have to make the bone grafting material. One of the best, I think that one of the top articles that I have read about flapless post-extraction, immediate implantation, how to deal with, do we fill the gap, no fill the gap, place it temporary or not place it temporary. This is a study of 2 parts done by Team Atlanta and Team New York. And they reached the result that always graft the gap and always try to place immediate temporization. If you were not able to place immediate restoration, immediate temporization, just place a customized made healing abutment just to keep your socket, your soft tissues from collapsing. So it's the material of choice that you are used to. We're not going to discuss fill this gap with the material, customized healing abutment, very simple to do that, and look at the final result. The minimum, this is day 0, this is the minimum collapse that you will get if you use this technique. This is 3 years later, maintaining almost 95, 97% of the contour of the socket. Stephen Chu, Maurice Salama, Henry Salama then tried to invent a new concept that has been mentioned now by a Christian coachman. It's the dual zone technique. What is the dual zone technique? I showed you that graft the gap. Now they started to say it's not only the gap. Extend your graft material up to the level of the soft tissues. Pack your graft material up to the level of the soft tissues. This is one of my cases. A grafting up to the soft tissues, not only the bone, not only filling the gap, up to the soft tissues, placing an immediate temporary, and you will see. Look at this. You will see some integration of the bone graft particles integrated into the soft tissues. Don't touch them. They're nice. If they are very well integrated, no problem, just don't touch them. And you'll see the follow-up 3 years later on that we have maintained the contour and the shape of the bone and the soft tissues. I'll skip this case. It's the same concept of the dual zone technique. But do we always have a buccal plate? All the cases that you saw now, we have a buccal plate. It's a type 1 socket. But in 60% of the cases, especially in the aesthetic zone, we don't have a buccal plate. And this is a big problem. What do we do? Of course, type 1, type 2, and type 3. Type 3 is not indicated. But they also divided the type 2 socket, which we have enough soft tissue, but we don't have enough bone. Some of the buccal plate had been resolved, type 2A, 2B, 2C. Well, what should we do in these cases? Reading the literature, they said, if you have a type 2A, little resorption, you are losing some of the buccal plate, you can just managing like socket preservation. Place your collagen membrane, pack the space with the bone graft material, and everything will be good. Okay? I'm a great surgeon. I'll do this because you can, by this means, reconstitute the absence of the labial plate. It's not what I said. It's Dennis Starno who said that. So I follow him. This is a case that I did, type 2A. I started with this case. Placed my implant in the exact 3D positioning as I learned after 7 years of immediate implantation. 1 year follow-up, you see, I had to a little bit mask with a pink porcelain. But still, year after year, if you look at the zenith line, I lost 1.5 millimeters, but over the years, this had been stable. 3 years and 5 years, the same zenith line at the same level. So it's predictable. when you have it type 2A. But for me, when I think that I'm a surgeon, I believe that I'm a great bone builder, so I can do miracles. So I place my immediate implantation in type 2C, which is absolutely no bone, no buccal bone, but still I had the soft tissues. But it's easy for me. I'm a great guy, great bone builder. Took out the root, placed my implant in the correct 3D positioning. I used all the technology I had, placed my PRF, placed my graft material. Everything was perfect. Placed my membrane. The patient was happy. I'm lucky that this patient, she's a friend, she is an anesthesiologist, she's not like Alain Roman said, she's not a blogger that has 2 million followers, so I'm on the safe side, because if you take a good look at the final prosthesis, I had to mask it with pink porcelain with extremely bad result. I'm lucky, the patient lucky, she has a low lip line. She didn't even accept to go to Alain Romanus to repair the case. She is satisfied. But how about the predictability of those cases? It means that it's not predictable. At that time, 2 months later, I was attending the EAO, and Dennis Starno was on stage like this, saying, no buccal plate, you have to answer no implant. And he keep going around all the area, shake hands with you, no buccal plate, you have to answer no implant. Because if you miss the buccal plate, you shouldn't place immediately the implant. You have to go staged. It's not late implantation, it's early implantation. We have to go for early implantation. Why? Because if you do the extraction, let the soft tissue heal. The soft tissue will spontaneously have more than 3 to 5 millimeters more of soft tissues, which is almost, they say that it's a 7-fold increase in the soft tissue thickness in the midfacial region. And this is very important. Well, for me, as a humble clinician, I follow the rules. I followed Dennis Sarno. So next time, if I had a case, I didn't do it immediate. I let the soft tissues heal, but I'm a great surgeon. I can do with the bone. So I let the soft tissues heal spontaneously. Look at the CBCT. The CBCT shows a typical type 2C socket. Then, placing my implant with all what I did osteodensification with the densifiers. I did everything that I have, placing PRF, placing PRGF, the titanium membrane, everything I have in my toolbox, I throw it with the patient. Did everything, collagen membrane over it, everything went great. And if you take a look at the final, and I placed a temporary, which is resin bonded, because I want something to contour the soft tissues. I want to get a good soft tissues. Well, 4 months later, I took a CBCT. Wow, look at the amount of bone that I gained. I'm the big guy. I'm the hero man here. Look, 5-6 millimeters you want bone? I did it. Unfortunately, I'm ashamed to say that after 20 months, I had a collapse. Just 20 months, 1 year and a half, I had a collapse. Oh my God, where did this bone go? I placed 5-6 millimeter, over-grafting all the time. Where did that go? Where did it disappear? Then I was reading Joseph Kahn when he said, facial recession will be more pronounced on a thin biotype rather than a thick biotype gum. At that time, because I think like a surgeon at that time, not a periodontist, we always crash with the periodontist. I was thinking only with the bone. I didn't pay attention to the soft tissues. I had the thin phenotype, now we call it. So if my bone graft material is not fully protected with the thick phenotype gingiva, this bone, whatever you get bone, it will never be preserved. It will disappear if you don't protect it with the more connective tissue, if you don't have enough thick biotype. And this is proven with the research. I'm not saying something. The thicker the bone, the thicker you get around implants and vice versa. And this is very well documented in the research. Additional surgical intervention is necessary when you are doing immediate implantation, especially in the aesthetic zone. Howie Gluckman and Jonathan Dutoit said to me, either if you place in both protocols immediate implantation or early delayed implantation, in both cases, you need to increase the soft tissues around your restoration for aesthetically satisfactory outcome. Of course, some authors would just prefer the pedicled flap. It's a matter of choice. But this patient, I would love to get this gingiva, this gum, pregnant, as Romanos say, pregnant in but 3 months. And it cost me nothing. Just a simple sushi, a piece of sushi inside here, and she got pregnant. And look, you can transfer from here to here with just a simple piece of sushi taken from the tuberosity, as Romanus likes. Habibi Romanus. When I was visiting Team Atlanta, we were lecturing together. The Agnini that you saw in the morning, you witnessed it, they were just creating something new, what they call it surgical veneer grafting. That means additional bone grafting over the buccal plate. Of course, it's a very reliable technique, and you can see with this case, atraumatic extraction, of course, flapless. I just raised partially so I can show in a picture. Placing your implant, one abutment, one time. Placing your overgrafting, surgical veneer grafting. I'm sorry for the photos, my assistant wasn't. So after 18 months, and even years, you can maintain, this is almost 3 years, and you can maintain all the contour just by the surgical veneer grafting, which is invented by the Agnini brothers. Now, when I met this man, he changed all my mindsetting. Marcus Horsler, he created a way, he thought out of the box. He wanted to fool the body. Whatever we do, any kind of graft material, any kind of method, you'll get a resorption, you'll get a remodeling. What this man created, this one, it was with you, Omid, in your, he wanted to fool the body because he knew that the main blood supplies that comes to the labial plate is not only from the periosteum over the labial plate, it's from the PDL. That's why if we do the extraction, the bundle bone will disappear. Now, he wants to keep this bundle bone, by not extracting the whole tooth, and you'll see now Howie Glockman will be in deep talking about this matter, just extracting a part of the tooth, leaving the labial part attached to the PDL and the labial plate. All this technique is called the root shield technique, and on the histologic level, on the clinical level, it has been proven is just fooled the body, fooled the biology. Howie Glockman, then, he is now one of the great masters of the socket shield technique. He invented new methods, and he made a very high-level study on the socket shield technique, which is now the treatment of choice when it's applicable for our immediate implantation. The idea is just, as I said, keep a shield or a part of the tooth attached to the labial plate. This is my first case, leaving just a small part of the tooth. This is the CBCT planning, and you'll see now, 2016, placing my implant in the excellent positioning. Look, 3 years later. Now, of course, we are not allowed in Syria to take CBCTs just for routine checkup. But from a clinical point of view, 5 years later, and now 7 years follow-up, you see that this contour did not change a bit. It maintained the full contour of the hard tissues and the soft tissues accordingly. I'll not waste a lot of time for the technique. I think that Howie Glockman is going to show you in details of the technique. It's technically sensitive. You have to take a course for that, so you can do it in the correct way. I'll skip this. This is the final result. After 5 years, this buccal plate and all the soft tissues and the hard tissues are maintained year after year. Thank you, Howie Glockman. He invented a special toolkit to make this technique not only more predictable, but more reproducible. So every general dentist, if he takes a course, it's a step-by-step procedure, so you can do the same socket shield technique with ease, and you can apply it in most of the cases of choice. Of course, this has been proven in literature, on the clinical level, and even on the histologic level. It works excellent in chosen cases. Of course, you have to choose the indicated case. A very large team of top clinicians in the world, they made a clinical study on partial extraction therapy, or this socket shield. This is a 10 years multi-center clinical study from top clinicians around the world, and it's all documented. If you make a review, I'll make a shortcut because time is running. The summary, if you just take a look, from the late 70s or the 80s, look how the immediate implantation has gone through numerous changes, numerous philosophy. We changed our mind setting, how to do the immediate implantation. And at that time, when I started to do the immediate implantation, I thought this is a complication. But as we go up in the learning, as we climb the learning curve, at that time we realize that we are changing the cutting edge. Those were not complications. Those were totally mistakes that we did unintentionally, because that's what we knew at that time. But until now, we do make mistakes. And I brought you all the mistakes from my own practice. It's not other practices. It's my practice in my hands. So the only way to avoid those mistakes, first, to acknowledge the mistakes. We have to confess that we do mistakes, either intentionally or unintentionally. And we have to know that the only way to prevent those mistakes is don't look at the Facebook. We have to learn. You are learning from this conference. Facebook and YouTube are informative. They are not educational. Yeah. Most of the complications that I see referred to my clinic and to Alan's clinic, whatever, they are mostly from some doctors who see a new technique on YouTube and think that they can do it easily. There are lots of hints, tricks that you will miss. Please, go for training courses. Implement your educational ability for the future. Attend courses, attend all the conferences you want, take very good courses. And I think that you can always find very good speakers very near to you to get those kind of courses. Please, the most important thing is that we all do mistakes. But the most important thing is never repeat those mistakes. With this beautiful view on my boat, from my town, I say thank you for your kind listening. I'm the perfect man, 5 minutes even before time, just to get, thank you.
On behalf of EDIC, we'd like to present this small token for appreciation.
Thank you.
Thank you very much, Dr. Emad.
Here, take. So, you like it?